I'd like to welcome Aníbal García-Sempere and Gabriel Sanfélix-Gimeno from Fisibio in Valencia in Spain, who are going to talk to us a bit about their work that they and their colleagues have been doing, recently published in Diabetologia, about a possible link between the GLP-1 receptor agonist drug class and suicidal ideation and self-injury. So perhaps could you start off because this GLP-1 receptor agonists, they've been in the news quite a bit over the last couple of years. So please, could you give me a little bit of background over what these drugs do and how they're being used to treat type 2 diabetes and obesity?
Sure. Thank you, Catherine. It's a pleasure being here with you. So with regard to glucagon-like peptide-1 receptor agonists or GLP-1 receptor agonists, they have been in the market for over 20 years now. To treat type 2 diabetes. But recently, as you mentioned, they have received a lot of media attention, a lot of headlines, making a lot of headlines in social media and so on, and due to their authorization for use for weight loss. So we are talking about drugs like exenatide, liraglutide, semaglutide, or the recently launched tirzepatide, which is unusual, which are very popular between the population that normally in Spain does not know about prescription drugs unless if they're taking them. But this is not the case for these drugs because they have a lot of popularity in these last months or years. So these drugs, what they do is they mimic or they copy a protein that is released by the stomach when we eat food, which is GLP-1. And this protein, what it does is it controls the production of insulin by the body. Insulin, what does insulin is to control the sugar levels in the body when needed. And they also reduce the amount of sugar of glucose that is released by liver, so even less glucose. And they also affect the process of digestion of food. So when we eat food, it slows down this process in a way that the sugar that is present in meals is absorbed in a very lengthier period of time. And this is linked also to an effect of reduced appetite. So you stay longer without the feeling of having to eat something. So in the last 20 years, they have been used a lot and they have been recommended by all clinical practice guidelines to treat type 2 diabetes. And also they have demonstrated to provide cardiorenal benefits in these patients and to ameliorate metabolic syndrome markers. In the last years, they have also obtained indication in weight loss because in the trials from type 2 diabetes and the researchers saw that there was an effect of weight loss, or a potent effect of weight loss. So after being authorized for weight loss management, these drugs have the potential to be given to a large number of population. So this combined with the media attention received, even the influencer attention, comes to mind people like Elon Musk or one of the Kardashian sisters promoting these drugs, even in a off-label way in TikTok and this kind of social media. And this combined with intensive and aggressive commercial practices have led to some concerns because it appears to be a very promising business, but of course there are concerns from a regulatory point of view because normally when there is an expansion of the use of a drug, it is linked also to a risk of potential misuse, which in this case is happening already. So these drugs are now used by people that has not been included in clinical trials, so we don't know if the risk-benefit is the same in this kind of people that in obese patients or in patients with type 2 diabetes and other cardiovascular or renal complications. And also from a public health standpoint, because as I mentioned, we are expecting to have a lot of population exposed to these drugs, and these drugs, as for almost every drug, are not exempt from a myriad of potential side effects. The more common side effects of these drugs, of GLP-1 receptor agonists, are gastrointestinal effects, which normally are mild to moderate, like nausea, vomiting, or diarrhea or constipation. But this can lead also to other more serious gastrointestinal effects, such as pancreatitis or bowel obstruction or gallstone attacks, for instance. There have been all other kinds of side effects reported, such as problems of vision loss, problems of shot allergic reactions, which may be severe, problems of renal failure, and low blood sugar. And for instance, you may also have heard about the Ozempic phase, which is a misleading term because this doesn't happen only with semaglutide, but with all the drug class, and it is due to a very fast weight loss, which translates in a kind of deformation of the face, because you have like a hollow face with sunken eyes, and your chin and your lips and everything changes its shape. And this could seem not very important, but in fact, it's leading to many patients to perform plastic surgery. And there is the risk also to trigger some mental health problems due to this. So all in all, we would say that we are facing a drug class that is very promising and that has shown a lot of effectiveness. But at the same time, this can be linked to side effects, which can be severe. So it is very important to assess the risk and benefits of starting this kind of medication in populations, especially in populations where these drugs have not been tested today.
So on the background of this large, massive growth of this drug class and the complexities surrounding how they can best be used, what led you in particular to look at the any potential links that there might be between GLP-1 receptor agonists and suicidal ideation or self-injury?
Yes, well, this came first from the Icelandic Medicines Agency back in July 2023. When they reported that 3 patients had suicidal thoughts and ideation and self-injury when taking these drugs. So this led to the European Medicines Agency to start a deep review of the safety of these drugs. And in parallel, the FDA started also to review reports of suicidal ideation. And in January 2024, January this year, the FDA issued a preliminary evaluation where they say they did not find a link between an increased risk of suicidality and the consumption of these drugs. But they recognize that due to several factors, among them the fact that those are very rare events, and the evidence the FDA had at the moment was from studies with a very small number of events, they still say that they cannot discard the risk, and they're still looking into the subject. With regard to the European Medicines Agency, we recently learned that they have issued also a news report saying that they have reviewed evidence and they did not find a link, but they still also recognize that there's a need for further studies to continue looking at this in different populations of the studies that are currently available. So that's when we saw that we could contribute to the area, because the evidence is scarce and the area is very sensitive. So we decided that we could contribute by looking at this problem and looking at the potential association in our populations, which is the population from the region of Valencia, in which we have the luck to have a very, very good electronic information system that brings us information about the 5 million people that live in the region.
Yes, I see you've got access to quite a useful and complex cohort of people living in Valencia. So could you explain a little bit about this cohort and then the population databases that you used?
Sure, Catherine, thank you for the question. Yes, actually, that is one of the biggest strengths, or one of the, so we use the Valencia Health System Integrated Dataset, also called BEAD, that is a publicly owned dataset that, as Aníbal commented, covers 5 million of inhabitants for a long period of time, from actually from 2008. And it has it's an exhaustive and comprehensive data set that has information about sociodemographic information, clinical information, and all the healthcare use. So we have information from primary care and also specialist care. We have the diagnosis, procedures of lab data. It's a very detailed data set. Also prescription information from ambulatory care, hospitalization care also, and emergency room. It can be linked also to other registries from public health, like the cancer registry, a vaccine registry. There is also a lot of registries, health registries that can be linked. All this information is linked to a unique identifier that is called the SIP number. And this is stored in one of the databases, the population information system, that basically has information on all the sociodemographic, the coverage information, also the employment information from income, status of income, and also, which is very important from this kind of studies, the death information, mortality information, and also cause of death. Some of this information that is available in BEAD is quite unique in Spain and also in Europe. For example, the prescription information system has paper-free prescription and dispensing, both, and this information is linked. So it allows us to estimate some information in very precisely, like adherence, or for example, in this study, we used different information to assess the per protocol analysis or the intention to treat. For the per protocol, we used dispensing data. This is closer to the exposure. And for the intention to treat, we use prescription data. Regarding the cohorts, we included, so it's a population-based cohort. We include all patients with obesity that were treated with both drugs, GLP-1 or SGLT2 inhibitors for diabetes. So we are including the whole population with these conditions.
So you'd say it's pretty representative of the overall population with diabetes in Spain and in other countries?
So we cannot generalize, right? Results to the general population in the world or even in between regions in Spain. That's true. There are different patient characteristics that could be different, variations in use of medications, variations in practice. But it is true that our results are consistent with the results that we have observed in other studies. And it makes us confident that, and it adds to the body of evidence that is already performed, right?
Great. Oh, thank you for, giving me a little bit of the background to the cohort. So you've obtained and gathered a lot of data from the cohort, looking at both the drugs that they were prescribed and eventualities. So how did you go about analyzing the data in order to perform this study?
Yeah, so the Health Statistics Research and Pharmacomedia Unit has extensive expertise in the field, working with real-world data from BEAD. It allows us to analyze different epidemiological aspects like disease incidence and prevalence, patterns of use of medications, also appropriateness of use and adherence of medications, safety and effectiveness, comparative effectiveness outcomes. So our expertise makes us help us doing this work, but we are a multidisciplinary group that has different profiles, like biostatisticians, physicians, pharmacists. We have economists. These are very variety of profiles that allow us to have a methodological background, strong methodological background, and that permits us to do this kind of studies, right? And also, yeah, we are probably one of the groups in Spain with more experience doing this kind of studies. We have a lot of collaboration nationally and also internationally. We've been working in many studies for regulators like EMA or FDA through consortia or through, for example, the most recent Darwin EU platform that is created to assess the safety and effectiveness of medications after post-authorization, in the post-authorization period. And regarding the access to the data, well, we have to we obtain pseudo-anonymized data from B through, and the procedure is not, I would say, not easy. We have to first we have to get the approval from the ethics committee, and we need to submit a protocol with all the specifics of the study. And after this, we will submit the protocol and the approval from the ethics committee to the data commission, which after the approval, they will transfer the data, anonymize, as I said, and there are several requirements afterwards. We have to keep this data in a secure environment. We cannot, we should not try to de-anonymize the data, and we can only use the data for the purpose of the study that has been approved. That limits us, of course, to share the data with others, with third parties, and also to share it through repositories or as a supplementary material in publications, of course.
Well, that makes sense because patient confidentiality is really crucial, isn't it?
Exactly.
And so you compared the GLP-1 receptor agonist with another drug class, SGLT2 inhibitors. Why did you choose the SGLT2Is as the comparator?
Yeah, that's a good question.
It's a key question, actually.
Yeah, because it's part of the design of the study. And when we talk about our findings, we will do it in a few moments. We'll underline that what is even, I don't know if more important, but as important as the studies themselves, as the results themselves, is the design of the study and the methodological decisions that we took to perform it. As Gabriel mentioned, now we have a strong methodological background. We have a lot of expertise in working with real-world data and in conducting comparative safety or effectiveness studies. So in this way, we are we observe all of the design principles, and one of these principles, when you compare the safety of interventions in the real world, is try to produce groups as similar as baseline in the baseline as possible, trying to mimic as possible again what you would do in a randomized clinical trial. So in this way, the first thing is you should try to compare the intervention you want to evaluate with another active intervention instead of, for instance, placebo. And departing from there, you analyze all the drug classes and you analyze the recommendation for clinical guidelines. And what we decided is to choose SGLT2 inhibitors, because those are recommended also very widely to treat type 2 diabetes, and a lot of guidelines they are recommended as an alternative to GLP-1 receptor agonists, especially for patients with cardiovascular complications again, and also chronic kidney disease. So in this way, even if the populations are not really the same, they are as similar as possible. That's what's the principle why we chose SGLT2 inhibitors as a comparator group. Okay.
That makes sense. And then you also carried out an analysis, propensity score matching, is it, to try to make the two sides of the two arms of the cohort similar?
Yes. In fact, other keys of the analysis was, of course, using adjustment techniques to try to control difference between the cohort at baseline, and to create like pseudo cohorts with similar characteristics in all the covariates that we have. So this is another point. And as we have going deep a little bit in the methodological side, I would like to underline here also that the design of the active comparator is accompanied by another feature that is key here, is the new user design. So this kind of studies is in pharmacoepidemiology is called like a new user active comparator design. These are the terms that are usually used. And this is all. Other interesting feature is that we require all the patients to be included in the study, either in the GLP-1 agonist or in the SGLT2 inhibitors, to have a washout period before without taking any of the drug of interest, which is, again, something we do trying to emulate, again, randomized clinical trial. So the idea when you try to evaluate or to identify causal inference with observational data is to mimic as possible what you would do in a randomized clinical trial. And this is what we're doing here. The use of inversity probability of treatment weighting also adds to this idea of trying to produce balanced group at baseline. And also, for instance, we use in a study, or we provided results, as Gabriel mentioned before, also in an intention to treat analysis, which is an analysis where you evaluate the decision of the prescriber who decided to assign the patient at the beginning to one group or the other group, and which is normally the common measure in randomized clinical trials. But as this is an observational study and it's a safety study, we thought that the main analysis should be the per protocol analysis, in which you do not look at only the assignment at the beginning, but at the actual exposure. That's why for the per protocol analysis, we use dispensation data instead of prescription data. So we're more close to exposure. So this is another aspect of the study.
Yeah, which is quite common, right? To use the per protocol or on treatment analysis for safety matters, right?
Exactly.
And as Aníbal said, sometimes we overlook the design part, and we look only in the analysis if it's sophisticated or not. But I think it's the key part. One of the keys is the design of the study. Yes,
exactly.
The decisions you take before you analyze the data.
Absolutely. Well, it sounds like you have a very robust study design in place. So what were your main findings from the study?
So we found no evidence of an association between an increased risk of suicidal thoughts and self-injury and the use of GLP-1 receptor agonists. So our results do not support the idea of a link between the exposure to these drugs and this kind of suicidality outcomes. So as I was mentioning, we perform intention to treat and on-treatment analysis, and we also perform several sensitivity and stratifying analyses. So we selected the more prevalent psychiatric conditions in our cohorts, which were depression, anxiety, and sleep disorders. And we looked at these groups separately. We also made analysis per sex assigned at birth. And finally, we also did an analysis with the body mass index data for the different strata of body mass index, because what we saw when we chose these populations is that even if we try to make it as similar as possible, what we saw is that, generally speaking, the people treated with GLP-1 receptor agonists were a little bit younger. There were more women also. And most importantly, they were more obese. There were a higher percentage of people in the higher BMI strata than in the GLP-1. So we performed there some analysis also working with this data. And we found consistent results all over the analysis, also adding to the robustness of our findings. But I would like to, again, just underline what Gabriel said, that in observational studies and in comparative safety and effectiveness studies, what is really important is for a good reading of the paper is to understand if the methods are correct and the methods ensure that the results are reliable.
Yeah, that absolutely is key, isn't it? And of course, because it's such a sensitive area, and obviously any health authorities or doctors or individuals would want to minimize any risk at all of suicide or self-injury. So on the background of that, how would you interpret the results that you have from your study?
Yes, we are talking about potentially serious events, and as you said, it's a very sensitive area. Also, we are facing events that are rare, that do not happen too much. And in fact, our estimates, even if we do not find a causal association, our estimates are relatively wide, the confidence interval. So we cannot fully rule out, as the FDA did in their communications, that a risk may exist. All available evidence is pointing at the fact that there's no increased risk, but we cannot fully discard it, and we still need more observational data to fully discard the relationship. So in this way, what we would say here is that we would advise patients to continue having their medication as prescribed, and doctors to continue prescribing medications following clinical guidelines as normally. But maybe it would be desirable that doctors actively ask for patients for change in the mood, the behavior, or the worsening of depressive symptoms and these kind of things. And ideally, maybe they should also be aware of patients with a potentially higher risk of developing suicidal ideation before starting treatment with this drug. So also taking into account this popularity explosion of these drugs, I think it's the moment to be very careful, even if our evidence does not show an association.
Yes,
Yeah.
that probably is one of the key things, that these medications are going to be used in a large amount of people, and yeah, close monitoring is going to be needed to detect safety signals. Yeah.
And perhaps people taking them without really having a full discussions with the doctor, if they're becoming available online, that could be an area of concern.
Of course, there is plenty of tutorials on YouTube. We checked them yesterday. There are plenty of tutorials on how to use these drugs, which is a little bit frightening.
Great.
Yes.
And there is already evidence, at least in our country, that in the private setting, which is not as controlled as the public, because this is a public health system, there has been a lot of prescription out of indication, so off label.
Yes, because in our setting, the public setting, the use is very restricted.
It's very controlled.
Yeah, I think it is in the UK also.
Yes, of course. But here, what they have done, the manufacturers or the marketing holders, is they haven't obtained a public price yet, but they are working the private market.
Yes.
So we have to be very, very careful here.
So is this something, do you hope to take this this topic further yourselves, to do some more in detailed or extensive research in this area?
Yes, of course. And many groups are working in this area now.
Yeah.
Yes, we have a metabolic research area, and diabetes is one of the most important, but also weight management.
We are adding weight management now.
Yes. So people that have been prescribed with GLP-1 receptor agonist
in Spain,
purely for weight management.
Yes, in Spain, the authorization for weight management indication is very recent. So we still don't have a lot of patients there, but it merits careful attention. Yes.
So yeah,
over the next few years.
we plan to first expand our research on suicidal outcomes, update the cohort.
Right.
So we have a larger cohort and also a larger follow-up.
Trying to tackle the problem of the variety of events. We will try to have more patients and make our intervals more narrow.
And also to evaluate, to assess other safety outcomes like gastrointestinal outcomes and also effectiveness outcomes. It has been shown that the problems with withdrawal of these medications with
weight gain,
yes. So it's difficult to assess this specific problem, but we're working on it also.
And are there other groups perhaps doing similar studies in different cohorts that you're aware of?
So EMA is working in this field. We know they are also through consortia or through the Darwin EU platform assessing the patterns of use of GLP-1 for weight loss, also other medications used for weight loss. Assessing other potential adverse outcomes like thyroid cancer.
Mm-hmm.
And yeah, other groups are working on cardiovascular outcomes also, safety in pregnancy. We are confident in that safety of GLP-1 array will be a topic, a priority for health systems for a while.
Yeah, it does seem to be a priority both of the EMA and the FDA, doesn't it?
Totally.
So watch this space, I suppose.
Right.
Well, yes. Well, thank you very much for talking to me, Gabriel and Aníbal, and I wish you the very best of luck with your future research. And I'm sure this paper in diabetologia is going to attract a lot of attention. It's very interesting and well conducted study. So thank you very much for your time.
Thank you very much, Catherine. We are thrilled in publishing diabetologia. So that's great.